Buchanan. I'm a disease management coordinator with Population Health, a nurse that calls folks mostly after they get home to give them that support and coordinate their care.
That's excellent. Thank you so much. And we have a username. It's JMB10002. And you are still muted. If you're, oh, there we go.
Hi, I'm Jan Blankenship. I'm also a disease management coordinator with Population Health.
That's wonderful. Thank you so much for joining today. And Melissa?
Melissa Phillips. I'm a nurse practitioner and I work in endocrinology. Majority of my patients are diabetics, but I do all aspects of endocrinology.
Excellent. Thank you so much. And Elizabeth?
Hi, I'm Elizabeth Minnick with West Virginia Project ECHO. I work with Mitra and I'm the project coordinator.
Awesome. Thank you. And hey, everyone, I'm Mitra and I'm the Project ECHO manager and I work with Elizabeth. So we'll just jump right in. Melissa, I'll pull up your slides for you. Just let me know when you'd like me to go to the next one and I'll do it.
Okay, so I was given this topic on insulin pumps and I actually need to put Dr. Barghouthie's name up there because we're trying not to reinvent the wheel for a lot of the work that we do. So she had actually presented a 75 slide lecture. So I have about half of the slides in here and some of them will actually be perused pretty quickly through. So this was a lecture actually done by Dr. Barghouthie for our fellows. Next slide. So as always, we start with some learning objectives and going to try to keep it pretty simple. Patients that should be or could be on pumps, learning the appropriateness of it, trying to just give you some pump terminology, and that sometimes is a big aspects for both patients and providers to learn, because all the pump systems also have their terminology, so it gets a little bit complicated. And then transitioning from regular subcutaneous injections to pumps, and then just trying to give you some of the different pumps that we predominantly see here in our clinic and would be out in your population as well. Not really going to get too much in interpreting the reports, but showing you a few of them because the interpretation process is very long and detailed. Next slide. Identifying patients for insulin pumps. Basically, patients should be 7 years and older for either types 1 or type 2. So a lot of people feel like they have to be a type 1 to be on an insulin pump. That's not really true. The age limit is also decreasing because of children getting, I don't want to say smarter, but definitely more technological savviness at younger ages. But normally the approved part by the FDA is 7. Read instructions on the pump screen. So obviously reading, but that's also a vision issue. So I had a lady that was actually on a pump and was blind. And then when she actually got one of the newer pumps with the touch screen, it was a disaster. So she actually had to go back to her old pump and then actually had to be removed from her pump because then we couldn't get it, and her previous touching capabilities were not the same. So these touch screens are not for everyone. Routinely checking blood glucose. So that talks about the compliant patient. So someone just kind of comes in for the first time and they never check their blood sugars and they're like, I want to be on the pump. And that's just really not appropriate. A pump is a delivery system and it's not really for all patients. And sometimes patients think that it's easier and it's not necessarily an easier thing. You have to educate them that it's just a different way to give insulin. The easier part is the toleration of needle sticks definitely decreases. So they have to be still checking their blood sugars and willing to learn how to count carbohydrates. So that is a requirement to the pumps as well. Next slide. So this is just pictures of the 3 most popular ones that I'll show you and kind of what they look like. Medtronic 670G, and that is the big one there on the left. And then you can kind of see that it has the meter where it says 118, The meter is right there underneath of it, and that actually links to the pump. So whenever they get a blood sugar reading from that, it would link into the pump. And then you can see the little sensor is laying there flat. It kind of looks like that little bubble, and that's the Guardian sensor. So if you have the sensor linking to your pump, those are kind of the sizes. The Medtronic also has now a 770 that's out, and it looks exactly like this one at the 670. It just has a different, I call it a brain for most people to understand it in patient world. And it has Bluetooth compatibility now, and also will eventually be having lower set limits on it. So you might see 770 as but it looks exactly like this one. Then there is the Tandem, there's a T-Slim, and that one works in conjunction with the Dexcom sensor, and that's where you can see it says Dexcom G6. The Tandem T-Slim is a blue or touch screen, so it feels a whole lot different. It is much smaller than the Medtronic pump. And then both Medtronic and T-Slims have tubing, so that is a big difference. So it is connected to the patient, and they do have a tubing when they're wearing their pump. And the Omnipod does not have tubing, so that makes it very convenient, and people like that aspect, especially more in pediatric world, I would say that. So that is the brain. The black box is the actual same thing as all the other black ones, but the pod that you see there is not a sensor, but it's the actual reservoir that holds the insulin. So it Bluetooths from the brain to the pod, telling it what to do. The Omnipod does work in conjunction with the Dexcom nicely as well. Okay, next slide. Components of the pump, I kind of did that. So the black box is the insulin pump. That's the delivery system, and it's normally most of them run on AA batteries. Some of them now actually will plug into the walls and have the ability to also recharge. The infusion set is the part where the wire is. So that is the part where you see on this person's hip, they're attached to the Medtronic, and looking at the slide on the left is actually the infusion set that goes into the skin. On the right side of the abdomen is actually the CGM, okay? Inside the black box is the reservoir, so that's another terminology. That's what holds your insulin pump, or holds your insulin. And for the Medtronic, this one holds up to 300. I have another slide that kind of reviews how much do these pumps hold in insulin, because some of these insulin resistant patients, certain pumps would be better because it actually holds more insulin. So then that little green thing there, all of these pumps have to be inserted. So they all have different insertion devices, and that's how does that actually poke into you. So it's amazing how many people think there's a needle inside of you. There is not, but there is a needle in this insertion device that punctures the skin. That needle retracts out, but leaves the catheter into the skin. So that is just a picture of the insertion device that connects to the infusion set. And they all basically work in that fashion. Next one. How to load these. There is, oh, it doesn't look, I hope it's there. When I did it last night, it looked like it, there it is. So we could go through each one of these and watch a YouTube video on how to fill these. So I think the biggest thing is when it says how to fill your pod with insulin, it's the bottom right hand. You can kind of see that there is that's the infusion device, and you end up poking into the infusion device and filling it with a regular syringe, and you fill the pod. So we teach you that, and actually whatever pump you choose, those reps will end up teaching you it. But like anything on all of these pump sites, if you go under Medtronic, they have a video that can teach you. So there is written material and videos to help patients learn how to troubleshoot, but also how to fill these pumps, cartridges, reservoirs. But if you actually push go on these and later on, you should be able to view them, but I don't want to, it's long, so we're not going to do that. Next one. Yep, that's going to run. We don't want it to run. There we go. So remember I said all of these hold different amounts of insulin. So Omnipod, people get really excited about the Omnipod because it's wireless, but honestly, this one is behind in the most technology. Tandem and Medtronic run more as a closed system and work with their sensors. Omnipod does not. Omnipod only holds 200 units. So when some of these insulin type 2 diabetics, it's not a good pump for them because they're going through cartridges like crazy. So like I just saw a lady right now that she takes on average 110 units a day. So if you had the Omnipod, you'd be changing your reservoir every other day. So that's kind of not a good one. So Medtronic holds 300, the Tandem T-Slims holds 300 as well. And then it's called T-Flex and it holds a 480. So I don't really have anyone on the T-Flex, and mostly because they get into the T-Slim and they can't buy out or change up and upgrade. So it's something that you kind of have to know from the beginning. And then I'll talk to you about different types of insulin concentrations that you can put in these pumps, which then in turn allows you to still utilize these pumps. So I have people on Medtronic pumps that have U500 in their pump. And so when I say 300 units, this is classically 100 unit insulin, Novolog, Humalog in it, but we do off-label stuff sometimes to utilize these pumps still. Next slide. There it is. I'm trying to remember my order here. So can I use U500 or Humalog 200 or regular insulin in the pump? The answer is yes. Next part, just click it again and it'll go in. So it is off-label. If you ever see someone on U500, they should be seeing an endocrinologist. I really don't think private or PCPs probably should be doing off-label U500 in their insulin pump. Because they're just not going to have the frequency of doing it to kind of understand and keep that accurate, but we actually can use it. It's 5 times more concentrated. So when you're figuring out insulin to carb ratios, those numbers have to be manipulated in the pump. And so their insulin to carb ratio will look different because they're in a more concentrated insulin. So we can do it, but it is off-label. Next, I think it talks about the U200. So the same exact thing, when it's 2 times more concentrated than that, you are again dividing, where in U500, it's dividing by 5. In basal rates, it's dividing by, in U500, you're dividing by 5, and U200, you're dividing by 2s. Your insulin to carb ratios get multiplied. So that's where I say, when you start to do this off-label type of stuff, you just have to understand how it's running and make sure you know what concentration is in the pump. So we do use 200, and that gets the ability to not change the reservoir so much. Next, talks about regular insulin. So we actually don't really use regular insulin in these pumps. I don't think I have anybody. And it just has to do with the way the medical makeup of the insulin. It tends to not go through a pump very well. Next slide. So this one's pretty simple. You can see here that the pump is attached and the reservoir sits in the pump. The tubing is what is attached to you for the Medtronic and the Tandem. And then that brown is actually your skin, the infusion set sits in it. And then the insulin comes through these continuous drops. That's the basal part of it all. And then the boluses will also be through there. Knowing that one of the things about a pump is that it is deeper in the skins. So you end up using less insulin through an insulin pump because of absorption being better. So you'll see in another few slides how the concentration or how we change the actual dose. So if you actually had 100 units of subcutaneous insulin, but we were going to put it to a pump, we would decrease it by 25%. So it would actually be 75 units that we use it. So this does help sometimes too. So when we talk about how much insulin are they on, expect that when they go to a pump that they'll actually need less insulin, and that's due to it being under the skin and a bit deeper. Next slide. Where can you place it? Those are all the places, pretty much everywhere. I've seen people also put it in their breast. I'm not saying I recommend it, but it's been done. So best absorption is abdomen. So we do promote a lot of that. And notice that I say abdomen, it goes the whole way around to the sides and on their love handles, so they can do it the whole way to back there. Pediatrics use a lot of the upper buttocks as well. Thighs probably have the least amount of absorption, but you can use your thighs as well. Next. So it's just some pump basics. So we talked about this using rapid acting insulin. So most commonly U500, Humalog, Novolog. There is rapid acting insulin also now called Fias. It is also not approved through the pump. I've seen it in a pump. I've taken patients off of it in a pump because I'm not sure how it actually works with the pump. So that is a more rapid acting insulin. So that's why it's not recommended, kind of like regular. So the within 15 minutes, it's entering into the bloodstream. That's pretty much similar to what we say even to subcutaneous insulin. The boluses and stuff can last for 5 to 6 hours. Just think of the same concepts as Humalog there. The peaks are in the first 1 to 1.5 hours. Next. So this is trying to mimic what your pancreas does. So you get the benefits of the basal insulin and old pumps, and I say old, and I'm going to call it more like the manual mode. That's the terminology that's used in Medtronic. It's a basal insulin rate that we actually determine. Okay, so that means that sometimes people need less basal insulin overnight because they're sleeping and resting. So we get to turn it down then, but then they need a little bit more during the day. But then in the afternoon, they don't need so much because they're busy and they're up and they're active. So their overall needs decrease. So it allows you to do that. Now we have sensors that connect to the pump and have these auto modes or control IQ modes, that all of that gets determined through the brain of the pump and really its algorithms, and delivers these basal insulin rates per the sensor. So a lot has changed in that. The bolus infusion is still the same. It's for your meals, it's for your snacks, it's for your coverage because you went high or you didn't give enough insulin earlier. So the pump allows both of those aspects to be done, and you're connected to the pump, so there's no additional sticks. Usually for someone that is on basal insulin, it could be Lantus once a day or Lantus twice a day. And so that's 1 or 2 injections, and then you eat 3 times a day. So that's 3 more injections, but you have a snack. So then it's pretty big. So that's 4th injection. So some people are up anywhere from 4 to 6, 7 injections a day. So the pump really gets rid of that aspect. Next slide. Definitions, you can actually put up all the definitions here because I'm going to kind of go through them pretty quick. So target glucose, that is a terminology that we use all the time, and that is set in the pump. And it is usually 120. Depending on the pump, you set a low target and a high target. Some other pumps just have 1 target rate. And so 100 to 120 is usually the target. That's where we want our blood sugars to be. Insulin sensitivity factor, think of it as your coverage. That is your coverage for high sugars or low sugars. There is a calculation, and right there it is, that you guys will be able to reference it. That is just a calculation for you to go on. In the hospital setting, we have, moderate coverage scales, we have intense coverage scales, and we have conservative coverage scales. And that's kind of using generic systems. The insulin sensitivity factor in a pump, you can really manipulate that to do lots of different things. So you don't have just so much genericness, but more specificity towards that person. Insulin to carb ratios, that is the same as what we would do even in injections. So do they get 1 unit per every 5 grams of carbs, or do they get it per 10 grams of carbs? There is a way to calculate it. And when you have new startups or someone you're just putting on insulin to carb ratio and they learn how to carb count, it is 500 divided by the total daily dose of insulin. So that gives you an idea of where you would start. And then you end up coming up with how many units per grams of carbs. I have people that are on 1 per 15 grams of carbs, and I have patients that are on 1 to 1. That means every gram of carb, they get 1 unit of insulin. So those patients are getting 20, 30 grams, 30 units of insulin per carb that they eat. Those also sometimes are not pump candidates because that's just so much, or they're on U500 in their pump. Active insulin time is another part of the pump that we have to determine. Really, that's somewhere between 3 and 4 hours. You can kind of read there so that you understand it better on what that means. But it's basically a bolus, and it tells you how long is that bolus going to hang around before it'll give more insulin on top of that. And it also prevents stacking. Most patients are on 3 to 4 hours. That's not something that we manipulate too much in a pump. Next slide. How to start and transition. I already kind of told you that subcutaneous insulin requires more compared to in the insulin pumps. So this is just the calculation. The other thing that's really nice is that when you are transitioning someone from subcutaneous insulins to the pumps, they also, these companies have worksheets. So that is on, all of this is on the worksheet. So it literally tells you that how much do they weigh, how much insulin are they presently taking, please divide this by this number, and it gives you. So this isn't something that you also have to memorize. Each pump will have a worksheet for you to transition them from subcutaneous insulin into a pump. And then when people are on pumps and we go into the hospital, we don't let them have their pumps on. Most of the time, they're requesting an endocrine consult to be able to do that for you, because there's the opposite direction as well. But for most people, you're actually transitioning from sub-Q to the pump. And again, it's not something that you have to memorize. The pump that they decide to use will have a worksheet, and you can work through it to determine it. The big thing is that you will need less insulin, as it says right there. You'll take the total daily dose, which this example is 80, and then you're going to take multiplied by 75%, and that is going to give you 60, where I had told you before, if we had 100 units, you would be on 75. So that's just the big thing to realize, is that you'll need less insulin. Next slide. So you'll have to calculate all these rates. The basal rate, that one's pretty easy. And a lot of times you should be figuring out total daily doses of insulin. And we take that total daily dose. So I'm going to use rounder numbers than this slide has, but say they're on 100 units of insulin a day. That's taking in their injectable basal, Tresiba, Lantus, and then also taking in how much Novolog, Humalog they take for their meals. And that is your total daily dose. And half of that will be, so for 100 units, half of that should be 50. And then the other half will end up being your bolus part. So when we have patients, sometimes people run basal heavily, and sometimes they run bolus heavy. So that's why when you're transitioning to a pump, we really just kind of take the total daily dose and kind of, I don't want to say restart over, but try to get them back into appropriateness, where they're giving boluses for all their foods, and that it's the appropriate amount. So again, this is on a worksheet to help you, but calculating insulin to carb ratios, I normally use 500 divided by the total daily dose. It says 450 or 500. I just tend to use the 500. I'm a round number type of person. And you also see rule of 17 or 1800. I tend to do both, and then I kind of come up with a number in the middle, and that is where your sensitivity factor, and sensitivity factor, again, think of that as your correction that you're going to do. So we do that. It's just a different terminology, even when we're managing insulin through injections. Next slide. Active insulin time, that's that usual thing that I said, that it's normally 3 to 4 hours, and we don't really move that too much. So these is the same as if you were adjusting someone on blood sugar readings, even on injections. So you want their fasting and pre-meal to be adjusted. If they're having lower blood sugars, you're going to decrease their basals. If they're having higher blood sugars in the morning, you're going to increase their basals. So that is done through the nighttime and fasting pre-meal type of thing. And we talk about 10 to 20% change. So that's the big rule. The 10% I encourage people to kind of utilize when you're just trying to do some baby changes, or your patient's nervous about overnight loads, or just want to do slight changes. But 20% is where you're going to kind of feel that the change has been made. So they're going to see a pretty good see an improvement in that. So 10%, just think of it as a slight change, and 20% as a greater change. So if post-meal blood sugars are greater than 60 above, then you're going to decrease your carb ratio. And if they're less than 30 above goal, then you're going to increase your carb ratio. So just kind of remembering, it's when you increase your carb ratio, you're giving less insulin. And that kind of sometimes is a hard thought process to make. And when you lower your carb ratio, you're giving more insulin. So the 30 and 60 is if your goal is 120, but right before their meal, they're running always 200. That is 60, definitely 60 above. So then you want to make the changes there, because you're not giving enough insulin. So you need to lower their carb ratio. So it's sometimes you have to slowly talk yourself through it, or prior to going in the room with the patient, make sure you have reviewed these numbers, so that when you're trying to explain it to them, because they also can sometimes confuse you because they don't understand the directions of when you lower something, they think they're getting less, but you're actually giving them more insulin. So that's how ratios work, and it sometimes is complicated for them to get the hang of it. Next slide. If I didn't totally confuse you there. All right, basic steps when you're looking at insulin pump download reports. I'm going to show you some reports, but it is pretty impressive what these pumps can show to providers. So this is another, I don't want to say issue, but you have to have the staff to be able to, generate these reports for you. I can go on and look at them, but by the time I sign in, I upload the report, I print it, or I look through the whole thing, I get into the patient's room. It's just incredible. So we have staff that actually downloads this report. When they, the nursing staff does it, hands it to me, and then I'm just looking at the reports. And I have my few that I pick and I like. But the few things that you are doing is looking to see, are they in range? And I'll show you where that is on some reports. We talk about APGs, which is their profile, and our goal for in range is 70 to 180. And that should be about 85% of the time. And if they're not there, that's where you need to go first and trying to get them in range. If they are a pump patient that also has a CGM, then you're definitely looking for their sensor reports. And are they in auto mode? Are they in control IQ? Are they in manual mode? Are they wearing their sensor? Sometimes they have it and they don't wear their sensor. So that's another issue of how to look at these reports is, do they have a sensor and are they wearing it? And then again, there's lots of different ways that these reports will be generated to you, and you just have to figure out which ones you like. And you're looking for trends, especially in your type 1s, because type 1s can do a lot of different things by the day, but you're trying to see what they're doing over the 2-week period of time or 1 month period of time. Next slide. Yes, Medtronic. So Medtronic's one of the pumps. Manual mode is where the provider is manipulating basal rates, is the best way to kind of put that. It is not being done by the sensor, but manual mode does allow the sensor to talk to the pump for the security. So when you hear some patients say, well, my pump will turn off if my blood sugar is low, that is still in manual mode, but that is one of the benefits of having a pump, is that, or excuse me, having a sensor that talks to your pump, because when the sensor says you're going low, it then tells your pump to turn off. So manual mode is basically the original type of modes that pumps ran in, and that we controlled basal rates and all of those other things, sensitivity, insulin to carb ratio, active insulin time. Next slide. So you can see here, this is just one of Medtronic's CareLink reports. But on the left-hand side, if you kind of, well, actually look on the right-hand side, I mean, it just probably looks like French to a lot of people. And it's like, what are all these lines? But the nice part was when you look at these lines, that there's always a symbol and graphs that tell us what everything means. So you can see that the basal rate is a continuous delivery by the pump, and you can see that it's the green line, and it kind of looks like a stair step sometimes, but that shows you that the basal rate is running the whole time. So in all these reports, you get used to knowing and learning what it means. But if you forget, there's always a symbol that goes on. You can see on this report that the little black dots are all blood sugar readings that they took. It also includes their insulin to carb ratio, so you can see how much insulin they gave. The squiggly line on the second side, it tells you that they are connected to a sensor. On the top line, it says they're not connected to a sensor. It gives you the times of days, and then obviously the days of the week also. So lots of information can come from these reports. It's almost scary because patients will be like, well, I do this and I do that. And then you're like, maybe they don't. So a lot of times it helps them. They kind of can't lie through anything because you see it anyway. Next slide. This is another manual mode report. I tend to use it a lot. I just kind of brought it up here again, showing you that everything has a symbol and can tell you if you're a color-coded person. This isn't a very good report because there's lots of yellows, and yellow means you're above goal. It means you're above the 140 that's set for this patient as far as targets. And then you can kind of see there's some blood sugar numbers that don't have the yellow or the red, and those mean they're at goal. And there's not so many of those. All those black dots or squares, excuse me, is their amount of carbs that they put in, and underneath the black is their insulin that they delivered. And sometimes there's a circle around it and sometimes there's not. If there's a circle around it, it means they picked that number and they manually chose it, versus just letting the pump tell them and they agreed to the number. So in manual mode, there's a lot of overriding that can be done by the patient, which is sometimes not always good, but it has the option. That's just one of those possibilities. The reds are low blood sugar, so less than 70. So we don't want to see too many of those either. And this one's called the Logbook report. Next slide. Auto mode, you've heard me kind of already reference that. That is definitely wearing the sensor. That is when the pump and the sensor are talking to each other 100% of the time. It is microbolusing for blood sugar readings. So when it reads 180, that pump is going to be trying to give more insulin, versus when it's 100, it's going to be giving less insulin. It has the ability to turn off, just as in manual mode does as well. But I don't, as the provider, do any type of manipulation to the basal rate. It is totally done through the closed system of the sensor talking to the pump via algorithms to determine how much insulin is microbolused. Next slide. So different reports for auto mode as well. Again, this is Medtronic. So again, you kind of have to learn, this is just from Medtronic. They kind of tell us which direction to look at this, but you can actually see how much time, if you're in the number 1, that gives us all the statistics. Like you can see that they're in auto mode. My vision's very low, but we'd be looking at the blue A because that's the most recent. And then the orangey peach is the prior upload. So it's a different set of dates. Blue is always the more recent, but you can look in there and see how much percent of time they're in auto mode. You can look and see what is their average total daily use of insulin that they're doing. You can look and see how many times they actually eat. You know, is it 4 times? Is it 5 times a day? You get to look and see how often are they making their set changes, and that should be every 2 to 3 days. It should not be 5 days, but we get that a lot too. Then the number 2, it talks about exits out of auto mode. Once they're in auto mode, that part in there becomes important, because trying to keep patients in auto mode and not being bumped back into manual mode is definitely a goal for better blood sugar control. Time and range, again, is that important 85% of the time between 70 and 180. And that bar graph tells you, so that green, it's like 70% of the time is what you want to see. You want to see very few pinks and reds. Those are low blood sugars. And then very few yellows and oranges, because those are high and super high ranges. The top is the 4th part, and that's just comparison. Like I said, the blue is the most recent. The pink is where they were before. In general, this one actually doesn't look too bad or too squirrely. If you think it does, I can show you some ones that look worse. But that's the hours of the day from midnight to midnight, and it is basically compressing all the information from a date range of 7 days and giving you those where they are most of the time in order to make adjustments. Next slide. This is more daily. This one is, see the pink bars there? That is the basal rate. And you can see when it's kind of pink and very squared off, it is working hard. It's giving lots of microboluses. You can see when it kind of goes away, you can see that the graft is also trending low, that their blood sugars are low. So you can see the basal rate goes away. And then you can sometimes see where it's up and then it's down. And that's where it's just trying to chug along and keep you. So that pink is, think of that as your microbolus basal rate. Then you can look and see how much insulin was delivered, how many carbs were done. Those are in the orange boxes. And then the sensor is the squiggly line. The blood sugars that they agree with get put in through the pump. So again, we could have an entire lecture on how to interpret these reports. It takes time to understand them. And again, we do them a lot here. So to me, sometimes I don't want to say it's quick, but it's like anything. When you do it a lot more, it's easier. You can also see in these pumps that they give you exit mode reasons, and on the bottom, it also gives you graft explanations. So you can, when you can't remember something, you can obviously look down and see what that, what it means. If it's a solid pink, line, if it's a black dot, or if it's green, or if it's gray, it gives you all those types of things. Next. Common issues that we see in pumps is, overnight highs and lows. And honestly, in the manual mode, that gets improved immensely. A lot of times that's why I really encourage my patients to use auto mode and to get the sensor to talk, because that highs and lows really balances out and our patients get better sleep. Pumps also can drive people, they can have fatigue from alarms and too many alarms beeping and buzzing at them. When they are in auto mode or they use Control IQ in the Tandem, you tend to see their overnight sugars just improve immensely. There's very few alarms. The microbolusing works and it keeps them in control. Sometimes when they have overnight lows, it's what they do right before they go to bed. You know, they gave too much insulin late at night. They ate a very high glycemic meal. So a lot of times that's an insulin to carb ratio fix. But when you look at these sensor tracing, sometimes you can see maybe at 4 a.m. they start to start to really go low. And then if they are in manual mode, you can actually decrease their bolus rates. If they're in auto mode, you cannot do that, but we don't really see a problem. It actually works. And if you do have overnight lows in auto mode or Control IQ, then most of the time it's a behavior change that we need to figure out. Maybe they're exercising in the evening and having some overnight lows and stuff like that. Morning highs, same exact thing, making sure they're doing insulin to carb ratios, making sure the basal rates are set correctly. Are they staying in auto mode? Those types of issues. But these are common issues. You guys can read through them. I don't have to read them for you, but when you see those happening, those are the types of things you'd want to consider. Next. The Tandem is the other pump that we see quite a bit of, and it works with the Dexcom G6. And I don't know if you're on social media, but lots of people talk a lot about the Tandem now because of its compatibility with the Dexcom. Next slide. Again, terminology. Basal IQ is kind of like manual mode and Medtronic. So this is where it will suspend on lows. It will also resume. If the lows get fixed pretty quickly, then the basal rate will also resume for you. It also will suspend hard, and it can automatically turn off stuff if it's sustaining. So basal IQ is just like manual mode, but it's the terminology that's used in Medtronic, or sorry, in Tandems. Next slide. Control IQ is basically, but it's not, but it is basically auto mode. So both of these companies kind of crack me up because we'll use the word auto mode and they're the Tandem company and they're like Control IQ, but it is very similar. They have a delivery system that does automatic corrections if you're going high. The difference in this is that manual mode and Medtronic gives microboluses. Control IQ is giving boluses due to rises. So we actually do control the underlying basal delivery system, and then it will adjust off of the underlying delivery system that's set by us. Versus Medtronic, we have no hands-on with it whatsoever. Okay, so, but you cannot run, you're either in Control IQ or you're in Basal IQ, but Control IQ is different than Medtronic's auto mode in the fact that we can control some underlying basal rates. Okay, next. So this tells you exactly what I kind of told you. Both require the use of the CGM. So you can't be in auto modes, you can't be in Control IQ without a CGM. They both require you to continue to use your food and boluses. If you don't do that right, it makes the pump very mad. It makes it very difficult for the basal rate to work appropriately when you don't do bolusing. So that's a lot of behavior patterns that we have to teach patients when they're in these auto modes, is making sure they're bolusing prior to eating, making sure they're counting their carbs correctly, because when they don't do that correctly, a lot of times they get kicked out because their basal rate either has to shut off too quick or it has to turn up too hard. So tend to do a lot of behavioral modifications for patients that are in auto mode. It's not really changing the system, but getting them to abide by the system. But both of them you can run outside of the auto mode if you choose to run by the old system manual mode, or you choose to run by Basal IQ. They are both there. Next slide. Some other things that people prefer one pump over the other, besides the actual pump itself, sometimes it has to do with the sensor. So Guardian sensor is the one for Medtronic. It requires calibration, which tends to be annoying to patients. And that's about every 12 hours. And basically they just have to do a blood sugar check in order to tell the pump that everything is still okay. And the Dexcom does not require that. So that's a major thing for patients. You wouldn't think so, but it really is. 670G. So it doesn't, so when it doesn't give boluses if you're going high, but the micro boluses will rev up. And in Medtronic's automaticity, it tends to get kicked out. You'll hear us say that because it doesn't give these extra boluses for the mistakes that are made in corrections of their insulin to carb ratios. Whereas the other pump, it will do that. It'll see that you're requiring more, and it kind of gives an additional percent of a bolus when it sees it goes high. It's why the two pumps actually just aren't the same. And they have their own algorithm and they have their own patents. So as a provider, we kind of just need to learn those differences, but the patient just kind of knows how their pump works. So you just explain it to them. As a provider, we have to kind of understand the differences, but to the patient, it doesn't matter to them because they just have picked their pump for their reasons, and then we move forward from there. So this isn't something that a patient really needs to know. It's just something that we need to know when we're working between different pumps. Next slide. Omnipod, that's my last one. And I really don't have very many slides, but to show you that that's the one that's the wire or tubeless. It will now work with Dexcom as well. And it will show some improved compatibility here over the next 6 to probably 18 months, where we'll see some of that automaticity developing through the Omnipod, but that is not available in the Omnipod right now. It just runs off of the old system. Next slide. This is more just to show you, this is the report that I showed you, the very first one. And just because it's a different company, look at how different this report looks. And as a provider, that's what we really have to get used to, is working with different reports and how they look. I probably have the least amount of patients on Omnipod. So of course it takes me a little bit longer to read through these reports, but they give you the same information. It's just kind of displayed differently and definitely with different colors. Next one. This is the logbook. If you remember back in Medtronic, that was the one that had like the orange and the red squares and the black squares. This is their logbook. So again, it provides the same information. It's just kind of laid out with different colors and put in different places. You still have all of the symbols at the bottom of the report. So if you forget anything, you can look down and say, oh yeah, orange means this, red means that, circles mean this, and circles mean that. So again, just showing you that it looks different, but they provide very similar information. And sometimes their terminology is different, but it's still all there. Next. So I put us all up here. We're adding new providers to our endocrine department. We're going to get 3 new providers. Actually, Dr. Turner is our fellow, and she'll be moving into a full-time provider here, as well as 2 other providers, and we're adding a pharmacist. We can't run our pumps without having people. So it's not just us, but it's really our diabetic nurses also that help us run these. It'll be pharmacists also now getting approvals and insurances to get things paid for, the complications of sets and reservoirs and batteries and failures and stuff like that. So, you know, having a pump patient is a difficult process, and you have to have lots of people to be able to do all aspects of it. So that's just giving you some of the providers that we have here. And then each company has a rep. So we have reps that come in here to our office and train our patients. So these patients do need to be trained. You can't just say, here's your pump and go look at a YouTube video. And these companies don't really let you do that. I think we have a few that come sometimes squeak through and don't truly get the training that they're supposed to. And that's more in patients, not on our efforts of trying. So a lot of teaching through each of these reps, and these reps are very knowledgeable. So when you're having problems, I would encourage you, you can obviously reach out to us, but I would encourage you to reach out to these reps, and we can give you the names of our reps, and depending upon where you are in the state would also determine where your rep is and if your rep is our rep and that type of thing. So, but we would be able to provide you with that and get you in touch. But if you have a pump patient, you need to also be in touch with your reps so that they can help you not only manage it, but help you troubleshoot through supplies and education processes, because we, as the person manipulating the pump or making the setting changes, I can't be the person telling you how to insert it and take it out and, you know, that type of thing. So we have them come in quite often to educate us as well. That's it. 55 minutes.
Thank you so much, Melissa. That was such great information and so important. And seeing all those different logbooks was super interesting too. So I appreciate you inserting images and everything. I'm a visual person, so it really helped.
Yeah, and people will be able to go back and just kind of read through some of it. I was trying not to read off the slide, but you can certainly go back and read it. And when you read it a little bit slower, it makes sense.
Absolutely, absolutely. Thank you so much. So we have about 4 minutes left. Did anyone have any comments, questions, or thoughts that they just wanted to share with the group? Feel free to unmute or chat in. I'm more than happy to read it out loud as well. Oh, Donna, I believe you are muted.
Well, that's not good. That must mean I was unmuted the whole time. Hope I didn't cough or anything. Melissa, that was very well done. I'm glad I had the slides because there was a lot of information there. I felt like I was looking at concert pages at those reports. That was very detailed. Great job. I worked in Head Start. I've mentioned this before, and we did 3 to 5 year olds in our centers. And I did have a couple children that had pumps in that age group. We usually, we always got a nurse to be with that child through the day, because we had I had 700 children. So I was not in one center. I took care of all of them. So we had nurses specifically that would come in and manage like what the meal was and things. But that did allow then that child to be in our center and socialize and everything. But they're great. And my gosh, they've come a long way since I saw that one 20 years ago.
Oh yes, these pumps are nothing like they used to be. I've been a practitioner for 6 years, but a nurse for 26 years. And these are pretty impressive devices now. Just as phones have changed, these have also changed.
Absolutely. I can only imagine how much the tech is changing in healthcare and everything. And Sarah, it's great to see you. We noticed you had hopped on as well. So we appreciate you joining the session today. Did you have any questions or anything? I don't want to put you on the spot, so if you don't, no worries at all, but we're just happy to see you.
Nope, no questions this time. We don't really do pumps out of here because we don't have the manpower, but I really appreciate that they do it for us.
Yeah, I think that's unfortunate, but it is true. I mean, you need some manpower to be able to do it. And so we get a lot of pumps here because of the manpower that is here. And it would be very hard for one person to do so many aspects that these pumps require.
The one question I have is, how do you get to look at the things on the pump? Because they won't let us attach anything to our computers. Do you have a specific set of computers that they're letting you actually upload that information from?
So yeah, and things are being moved a lot to Bluetooth. So there's a lot of connecting things that we have to do with our patient and sharing passwords and getting it on. So yes, I guess we do have certain pumps, but it's also learning and we have passwords that are shared amongst us through the company that we can download, and then the patient has to give us permission to be able to do it. So actually patients can upload from home now. And during COVID, that was a huge thing to try to get patients connected to our clinic so that we could do it from their computers to our computers. When they're here in the clinic, then we can just, we just plug it into this computer and it downloads through the site, either Tandem, Medtronic, or Omnipod site, Gluco. And now things are moving Bluetooth. So it's really impressive. Like we can look at any point at any time because they're always connected. So that's again, another possible, reason, like you could have a pump patient, but then how do I look at all that stuff? So COVID did make us get a lot more patients used to have to come to the clinic to do it, but now they can actually upload from home. So I have pregnant patients that I barely see in the clinic. They upload, we just talk on the computer, and I have their devices, their reports already here in the clinic, and I don't even have to touch them. So it works nicely for telehealth once we can get them connected because of that. But yes, they're probably, for some companies or some private practices, you probably do hit a roadblock as far as that. But we work directly with Medtronic site, and theirs is called CareLink. And then Tandem, I forget what theirs is called. They work through, I think, Gluco. And then Omnipod also works through Gluco.
Awesome. Thank you all so much. And Melissa, I do want to say I appreciate you adding that last slide with all the hub members and the new folks who are joining the hub.
Oh,
We're
yes.
super excited for that. And Elizabeth's been working super hard creating the curriculum for the second half of this year, making sure they have like slots to present and everything. So just seeing the multidisciplinary team will be so awesome.
Yes.
Thank you for that. Alrighty, we're 1 minute over our session hours, so I do apologize, but that was such a wonderful session. I appreciate each and every one of you joining today. Huge shout out to Melissa for presenting today. We appreciate you guys.
All right, thank you.
Thank you. The only announcement I have today is that our next session will be on June 23rd, and Dr. Haydar will be presenting on any requests that we get from participants. So if you guys have topic requests for next time, just shoot Elizabeth and I an email and we'll send that over to Dr. Haydar. So thank you all so much. We'll see you guys next time.
Thank you.